Welcome to the Deep Dive. We take interesting research, break it down, and get you the key takeaways quickly.
Glad to be here.
Today, we're digging into something called May-Thurner Syndrome, or MTS. We've got a really interesting paper from 2017.
Yeah, it's from the Journal of Vascular Surgery, Venous and Lymphatic Disorders. It's titled Contemporary Outcomes After Venography-Guided Treatment of Patients with May-Thurner Syndrome, Rollo and colleagues.
Okay, so May-Thurner. Remind us quickly, what is that?
Basically, it's when the main vein coming up from your left leg, the left common iliac vein, gets squeezed.
Squeezed by what?
By the main artery going to your right leg, the right common iliac artery, which crosses over it. Now, lots of people have this anatomy,
Right.
but it doesn't cause problems. But for some, it really does. It can lead to symptoms.
And that's what this study looks at, the symptomatic cases.
Exactly. It helps us understand what happens when those symptoms are significant enough to need attention, and specifically how treatments guided by venography work out.
Venography.
Yeah.
We'll get to that. So the central question for this deep dive, based on this Rollo paper, is what are the outcomes when you treat symptomatic May-Thurner using this venography-guided approach?
Precisely. The authors looked back at their own patients with suspected MTS. They wanted to see, which treatments work best, and maybe even more importantly, who really benefits from an intervention versus maybe just conservative care.
Got it. It's about the different ways MTS can show up and what works for whom.
Right. From, say, just some leg swelling all the way to more serious clots.
Okay, so let's talk about that spectrum. According to the paper, what are the main ways MTS presents?
Well, they really focused on two main groups in their study population. First, you've got non-thrombotic MTS.
Non-thrombotic, meaning no blood clot.
Exactly. No DVT. These patients made up about 51%, so just over half. Their main issues were leg edema, that's the swelling, and something called venous claudication, which is basically a heavy, achy pain in the leg that comes on with activity, like walking, and gets better when you rest.
Interesting. How common were those symptoms in that group?
Well, 100% of them had the leg swelling, and about 47% reported that venous claudication, the pain with activity.
Okay, so that's the non-thrombotic group. What about the other half?
The other 49% had thrombotic MTS. So in these cases, the May-Thurner compression was actually associated with a deep vein thrombosis, a DVT, a blood clot.
Right. The clot complicates things.
It does. Now, interestingly, they also all had leg swelling, 100% again. But even more of them, about 74%, reported the venous claudication pain compared to the non-thrombotic group.
So swelling common to both, but maybe more activity-related pain if there's been a clot.
Seems that way in this group, yeah. The key takeaway is swelling was universal in the symptomatic patients they studied, but the presence of a clot was the big differentiator.
The study also mentioned CEA scores. What do those tell us?
Yes. CEAP is a clinical scoring system. Think of it like a standard way doctors grade how severe someone's chronic vein problems are. CEAP.
Higher score, worse problem.
Generally, yes. And what's interesting here is that the average CEP scores when patients first came in were pretty similar between the two groups. It was about 3.06 for the non-thrombotic group and 3.23 for the thrombotic group.
So even though one group had the DVT, their overall vein disease severity, at least by this score at presentation, wasn't drastically different.
Exactly. It gets us a baseline showing both groups had, significant chronic venous issues bringing them in.
Okay, that sets the stage. Now the treatments. What did the study find about how these patients were actually managed? And, crucially, what happened?
Right. So the main focus was on this venography-guided intervention. Venography, first off, is basically an X-ray procedure where they inject contrast dye into the veins to make them visible.
Like a roadmap for the veins.
Exactly. And the guided intervention based on that roadmap was mostly placing a stent.
A stent, like they use in heart arteries.
Similar idea, yeah. A small metal mesh tube put inside the compressed iliac vein to prop it open and improve blood flow. That was the main treatment.
Okay. Was that it, or were there variations?
For some patients, specifically those in the thrombotic group with the clot, they sometimes did thrombolysis first.
Thrombolysis, clot-busting drugs.
Correct. Using medication, often delivered via a catheter, to dissolve the clot before placing the stent. Overall, about 70% of all the patients in the study ended up having a successful intervention like this.
70%. And how did that break down? Was it mostly stents?
Yeah, of those who got an intervention, about 70% had just primary stenting, so stent placement directly. The other 30% had that thrombolysis first, then the stenting.
And what about the other 30% of patients overall, the ones who didn't get the intervention?
Right. There was a group managed more conservatively. That included 14 patients from the non-thrombotic group who were treated mainly with compression therapy. Think special stockings or wraps. And there were also 5 patients from the thrombotic group who had treatment for the clot, maybe lysis or just balloon angioplasty without a stent left behind.
Okay, so now the big comparison. Stents versus no stents, or at least not primarily stents. What were the outcomes?
Well, the differences were pretty significant. Really quite striking, actually.
Oh, so?
Okay, the clinical improvement. Improvement in symptoms. They found 95% of the patients who received stents reported significant improvement.
95%? Wow. And the non-stented group?
Only 58% reported improvement. Big difference there.
Huge difference. What about those CEAP scores? Did they get better?
Yes, same pattern. In the stented group, 77% saw their CEAP score decrease, meaning their underlying vein disease severity lessened.
Okay.
In the non-stented group, only 32% had a similar decrease in their CEAP score.
So it really looks like for these symptomatic patients, the stenting made a much bigger impact on both how they felt and the objective measure of their vein disease.
That seems to be the clear message from these results, yes. Especially in the short to medium term they looked at.
Did they look at complete symptom resolution? Like symptoms totally gone?
They did. And again, a big gap. Complete resolution was achieved in 64% of the patients who got stents.
Okay, almost 2/3.
But only 21% of those who didn't get stents.
Right. That really highlights the potential benefit of the stent for symptom relief.
Absolutely.
Now, any procedure has potential downsides. Were there complications reported with the stents?
They did report a couple of issues. There were 2 cases of early reocclusion.
Meaning the stent blocked up again soon after it was placed.
Exactly. But looking a bit longer term, the results for keeping the vein open, what we call patency, were actually very good.
How good?
At 2 years, the primary patency rate, that means the stent stayed open without needing any further procedures, was 93%.
That sounds pretty good.
It is. And the secondary patency rate, which includes cases where maybe a touch-up procedure was needed to keep it open, was even higher at 97%.
And how long was the follow-up?
The average follow-up time was just over 20 months. So, close to 2 years on average.
Okay, so generally good patency in that time frame. So putting it all together, what did the authors themselves really emphasize? What were their main conclusions?
Well, they spent quite a bit of time discussing the non-thrombotic group. These are often younger patients.
Right.
And the question is, who among them really needs a stent, especially thinking about having it potentially for decades? Their main point was that just seeing the compression anatomically isn't enough.
So not everyone with the squeezed vein needs a stent.
That's what they argue. They stress that their decision to stent was based on a combination of things. First, the patient had to have tried and failed conservative therapy, like the compression stockings.
Okay, that makes sense. Try the simple things first.
Right. Second, their symptoms had to be significant, really impacting their quality of life. And third, crucially, there had to be specific findings on that venogram, the X-ray dye test.
Back to the venogram. What were they looking for there?
They were looking for signs that the compression was actually causing a physiological problem, a real disturbance in blood flow, not just that the vein was narrowed.
Like what kind of signs?
Things like the contrast dye pooling or stagnating in the iliac vein, suggesting flow is slowed way down.
Okay.
Or seeing lots of collateral veins, basically, the body trying to build detours around the blockage.
Like side roads because the highway's jammed.
Exactly. Or even seeing the contrast dye crossing over to the other side of the pelvis through other veins to get back to the heart. These signs suggest the blockage is hemodynamically significant. It's actually impeding flow.
Got it. So symptoms plus flow disturbance on the venogram. What about IVUS, intravascular ultrasound? Where did that fit in?
This was interesting. They explicitly stated they did not use IVUS to decide if a patient needed a stent.
Oh, because IVUS is often talked about for diagnosing this, isn't it?
It is, and it's very sensitive for seeing the compression itself. But their point was, IVUS might show compression even when it's not causing a flow problem or significant symptoms. They used IVUS after the decision to stent was already made.
For what purpose then?
More for the technical aspects. To help choose the right size stent and make sure it was placed perfectly across the compressed area, guided by that detailed internal view IVUS provides.
So venogram and thinkums for whether to stent, IVUS for how to stent optimally.
That was their algorithm, yes. And they noted they had 100% technical success in actually implanting the stents when they decided to do it.
And they obviously highlighted those outcome differences we talked about, the better improvement in symptom relief with stents.
Absolutely. They pointed to the 95% improvement, the CEP score reduction, the higher rate of complete symptom resolution in the stented group. But they also made a really important observation about the non-stented and non-thrombotic group.
What's that?
During the study's follow-up period, none of those patients who were managed conservatively just with compression mostly experienced worsening of their venous disease or developed a DVT.
Ah, so for that specific group, not stenting didn't seem to lead to immediate disaster, at least in this time frame.
Exactly. Which suggests that for some patients, particularly those without a prior clot, a trial of conservative management might be a perfectly safe and reasonable first step.
This really gets to the heart of the debate, doesn't it?
Yeah.
How do you decide who needs what? It sounds like these authors are firmly on the side of needing more than just anatomy.
Yes, that's a major theme in their discussion. They acknowledge the ongoing controversy about the optimal criteria for treating symptomatic left common iliac vein compression.
The LCIV compression, right?
Correct. Their core argument is against relying only on an IVUS finding of compression to trigger treatment.
Why? What's the concern?
The concern is overtreatment. We know from other studies, just looking at imaging, a significant number of people walking around without any symptoms actually have some degree of iliac vein compression visible on IVUS.
So if you just used IVUS, you might end up stenting a lot of people who wouldn't have developed problems anyway.
That's the worry they raise, especially, again, in these younger, non-thrombotic patients. You have to weigh the potential benefits against the potential long-term risks of having a stent.
There are those risks.
Things like the stent potentially fracturing over time, migrating and moving, restenosis where the vein narrows down again inside or next to the stent, or even complete occlusion blockage of the stent. These aren't guaranteed to happen, but they are possibilities you have to consider over decades.
Right. So their approach is more selective, using those venogram signs of flow disturbance plus symptoms as the main drivers.
Precisely. Physiology and symptoms, not just anatomy seen on IVUS, should guide the decision, is their argument.
Okay. Now, no study is perfect. Did they mention any limitations?
Yeah, they did. They acknowledged it was retrospective, looking back at records, which can have biases.
Right.
And also that their assessment of clinical improvement wasn't done using standardized formal quality of life questionnaires. It was based more on clinical assessment at follow-up visits.
Okay, good to keep in mind. But despite that, they feel this work is important.
Definitely. They position it as a key study supporting the selective stenting strategy, one that requires both significant symptoms and those objective venographic signs of flow problems, with IVUS then used to optimize the procedure itself.
So the idea is to be careful, avoid putting in stents unnecessarily,
Right.
but still achieve excellent outcomes for the patients who genuinely have symptomatic flow-limiting disease.
That's the balance they're advocating for, trying to hit that sweet spot.
Okay, so let's try and wrap up the key takeaways from this deep dive into May-Thurner and the Rollo paper.
I think the big picture is that venography-guided treatment, primarily stenting, seems to work very well in the short to medium term for patients who are clearly symptomatic from MTS. You get good symptom relief, good vein patency.
But there's a but, especially for the non-thrombotic group.
Yes. For those patients without a history of DVT, the study that's just trying conservative management first, like compression, might be a safe initial approach. The decision to stent them should probably be reserved for those with persistent, significant symptoms and those clear signs on the venogram that blood flow is truly being obstructed.
Okay. And it highlights that the conversation isn't over, right? There's still discussion about the absolute best way to diagnose and decide on treatment.
Definitely, especially for those younger patients without clots, where the long-term implications of stenting aren't fully known over, say, 30 or 40 years. We just don't have that data yet.
It's an evolving field.
It absolutely is.
So maybe a final thought for you, the listener, to consider. We know this anatomical compression, this squishing of the iliac vein, is actually pretty common. So what does it really mean to understand the specific physiological markers, those venogram signs, perhaps others that separate the people who will eventually develop symptoms and need treatment from the many who won't? What kind of research could help us get even better at predicting that, refining who needs what, and figuring out the best long-term strategies?
Yeah, it really underscores the complexity. It's rarely black and white in medicine. You have to weigh multiple factors.
Indeed. Thanks for joining us for this deep dive.